Good afternoon, everyone, and welcome to SAMHSA's Gain Center's webinar, Effective Implementation of Risk Need Responsivity in the Treatment Court Setting. I am Dr. Melissa Neal, a Senior Research Associate with the Policy Research Associates, and I'm also the lead for communications out of SAMHSA's Gain Center. We have just a couple of housekeeping slides to cover with you. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. And throughout the presentations, we welcome you to submit questions. On the right side of your screen, you should see a Q&A pod, which you can click on. And throughout the presentation, feel free to submit questions. And after the conclusion of the last presentation, we will address as many questions as we can with our presenters on the line. You also may have seen a couple of polls pop up, and we really appreciate if you will participate. These polls will help us learn who has joined us today and understand our audience just a little bit better. And then finally, this webinar is being recorded and will be shared following this presentation. Just a quick look at our agenda. First, we are excited to have John Berg from SAMHSA here today to provide some opening remarks. And then we have three presentations by Dr. Faye Taxman, Dr. Douglas Marlowe, and the Honorable Peggy Davis. And then, as I mentioned before, we'll end with sufficient time to cover your questions. But first, I want to turn it over to John Berg for some opening remarks. John?
Thank you, Dr. Neal. Welcome to today's webinar, Effective Implementation of Risk Need Responsivity in Treatment Court Settings. We appreciate you taking the time to participate in today's informative webinar. SAMHSA is interested in promoting evidence-based practices, and for the assessment and treatment of offenders, the Risk Need Responsivity model is an EBP that is considered to be highly important. This is especially true for delivering appropriate and effective treatment for drug court clients and effective implementation of drug courts. The implementation of RNR has been shown to effectively reduce recidivism, and research has shown that non-adherence to the RNR principles in service delivery is not only ineffective, but can also be detrimental to offender treatment outcomes. RNR has been shown to reduce criminal behavior and improve public safety, and improve the distribution of treatment services to offenders in prison, jail, and community correction settings. We are excited to host today's webinar to present the Risk Need Responsivity model and its implementation in drug courts to provide a comprehensive system of care for criminal justice involved individuals. I would like to thank the Gain Center and their staff for their work in developing and facilitating today's webinar. We are pleased to have three very distinguished presenters today with great expertise in this area, Dr. Faye Taxman, Dr. Doug Marlowe, and the Honorable Peggy Davis. At this time, I will turn it back to Dr. Neal.
Thank you, John. And now we're just going to briefly introduce our presenters today. And as John just mentioned, if you have done any work looking into or studying RNR, you'll be familiar with our presenters. First, Dr. Faye Taxman is a university professor in the Criminology Law and Society program at George Mason University. And she has tremendous experience in the development of seamless systems of care models that link criminal justice with other service delivery systems, experience in re-engineering probation and parole supervision services, as well as organizational change models. And she's received and oversees numerous grants and active laboratories through agreements with the Maryland Department of Public Safety and Correctional Services and Virginia Department of Corrections. Dr. Doug Marlowe is a senior scientific consultant for the National Association of Drug Court Professionals, NADCP. He is a senior science and policy advisor for alcohol monitoring systems and is a training consultant for the Global Institute for Forensic Research. Previously, he's served in a number of roles as Chief of Science, Law, and Policy for NADCP, Director of Law and Ethics Research at the Treatment Research Institute, and Adjunct Associate Professor of Psychiatry at the University of Pennsylvania School of Medicine. And he also serves as the editor-in-chief of the Journal for Advancing Justice and is on the editorial board of Criminal Justice and Behavior. And we also have with us Honorable Peggy Davis, and previously she was the Treatment Court Commissioner of the 31st Circuit Court in Missouri, and also has worked as the Assistant Prosecuting Attorney for Greene County, Missouri, as well as the Public Defender for the state of Missouri. And she is a past president of the Missouri Association of Treatment Court Professionals. Currently, she serves as a senior consultant for the National Association of Drug Court Professionals and as faculty for the National Judicial College. And so now we will turn it over to Dr. Faye Taxman to kick us off with her presentation.
Good afternoon, and thank you very much for this opportunity to talk about the risk needs responsivity model, particularly as it applies to problem-solving courts. So today I'm going to go through very quickly the framework for the risk needs responsivity model as it applies to a public health approach, which is the next generation. A lot of people have heard of RNR more from a criminal justice perspective, but as the field has advanced and new research has occurred, we actually have some adaptations to that model. I first want to begin with the notion that we know a lot that works. For example, we know problem-solving courts are very effective at reducing recidivism. And this chart here, right here, which is has three colored block boxes, the red box meaning these are the things that the scientific literature has determined are not effective in changing behavior, reducing recidivism. Those items in yellow reflecting the areas in which we have emerging evidence and evidence that suggests that better implementation of those particular initiatives would actually lead us to improved outcomes. And then the third box in green are those area programs and services and interventions that actually are effective in reducing recidivism. And you can see on the side that starts with intensive supervision, those are the criminal justice per se interventions. And then the side on the left-hand side, my left-hand side, that talks about some of the behavioral interventions. So problem-solving courts are effective, but it also depends upon the type of treatment services that are offered. And as you can see, we know that cognitive processing groups, the cognitive behavioral therapy, therapeutic communities, and the use of medically assisted treatments enhance the effectiveness of interventions to really change behavior. And this is important because your drug court or your problem-solving court not only should feature the core 10 components that NADCP has articulated, but also should include enhancements to make sure that we're providing quality treatment services. The risk needs responsivity model was actually formulated in Canada by Don Andrews and Jim Bonta. Their model was essentially that if we know the risk level of clients and if we know the needs that affect their criminal behavior, and we provide them with responsive programming, either programs that are prioritized to include social learning models, cognitive behavior models, and tailoring that to the individual, we can actually reduce recidivism. In the public health framework, we are adding in destabilizers, not necessarily just some of the criminogenic needs, but some of the destabilizers like mental illness, housing instability, food insecurity, that actually contribute to negative outcomes. And we do that because we know that in order for a person to do well in a problem-solving court, not only do we need to attend to their treatment, but we also have to have them stable enough in the community so that they could benefit from those treatment services. The risk principle, RNR Principles, basically is based upon the risk principles. Who should we target for what types of services? Need principle, what should we target in terms of reducing recidivism? In other words, the drivers of recidivism. And then responsivity, where and how we provide these services and the nature of those services to address the unique characteristics of individuals such as gender, ethnicity, age, culture, motivation. The risk principle is very important because the risk principle essentially tells us that the more we target higher risk individuals, the more likely those individuals are to need intensive services and controls like those that are provided within problem-solving courts. And the need principle is important because it tells us what behaviors we need to really deal with. So we know that people come in all sorts of mixes in terms of their combination of risk and need, and it's important for us to understand those to make sure that we're actually trying to target those that are likely to have improved outcomes. Now, just clear definitions. I know that you probably all have heard this, but risk here refers to the likelihood that an individual will engage in further behavior. Risks are the static factors, the things that typically don't change the first time someone got arrested, the number of times they were arrested, the type of criminal history, the number of times they've been on probation and parole, the number of times they've revoked, age of first incarceration. This is what risk is about, and these factors are not changeable. What is changeable is the needs. And needs here refers to dynamic risk factors that are related to criminal behavior that can be changed, and that through effective treatment interventions and the activities of a problem-solving court, we can actually make great headway. Here we want to deal with issues like low self-control, antisocial personalities, antisocial values, criminal peers, substance dependence, dysfunctional family, and the deficits that people bring in terms of their education and employment backgrounds. When we talk about substance use disorder, we all know that this is a term that's widely used and that good standardized instruments are useful for helping us to decide at what level of severity is this particular person. And this is important because problem-solving courts are more likely to help people who have more severe problems because of the intensity of the services and the ability to provide a number of wraparound services. So problem-solving courts are more likely to be geared and should be geared for people who have moderate to severe substance use disorders and those who meet the pharmacological criteria for need of medication to assess with helping the person achieve some recovery. Stabilizers are something that we should look at here, and those are the factors that enhance the likelihood of success for a particular person. These are the positives in people's lives, and these are the strengths that we try and draw upon. Destabilizers are those factors that make it difficult for clients to actually make some headway. And those include unstable housing, different types of drug abuse and alcohol abuse disorders, mental health history, food insecurity. These make it hard for people to participate and gain from treatment services because their focus of attention is really on just trying to meet the day-to-day basic functions. The responsivity principle tells us that we really need to think about combining the controls and treatment to address these static needs and risk factors. Problem-solving courts are, of course, ideal for this because the court has the ability to do both treatment as well as provide controls. What's most important, though, is to keep in mind the type of treatment services that should be used to augment what happens in the problem-solving court and to be sensitive to using treatment services that are better suited for individuals. So some good RNR public health principles to consider are the use of a standardized risk needs instrument. We refer to this as the third generation. It's a validated normed instrument, normed to your courts. And it should include the social determinants of health because knowing about food and housing and mental health status are really critically important to get good outcomes. Use of a case plan, targeting a person to appropriate programs and services based on their risk and needs, and then making adjustments along the way as the person succeeds or has some setbacks. Okay, so let's apply this more so to problem-solving courts. So one thing we know about problem-solving courts is the importance of making sure the right type of client is in the problem-solving court. This is a study that was done in Kansas, and the blue lines indicate the reconviction rates of people that do not have the need that is identified in the left hand on the y-axis. So what this means, and the right area indicates clients that do have those needs. And you can see in all of these different bars that the red bar is smaller than the blue bar. That essentially means that when you match clients to the appropriate service, you're more likely to get reductions in recidivism than when you put people into any program or services. And that's an important part because a big part of the problem-solving court is to make sure we're screening for people who have a more severe substance use disorder and who present some public safety risks to the communities. Determining the level of care is not always easy, and it requires a combination of risk levels, needs, clinical destabilizers, and lifestyle factors. All of these are important in terms of how we would think about who's eligible for a particular program. In order to help people apply these principles, we basically have come up with a hierarchy of needs. So clients who have substance dependence, criminal thinking, are more suited for higher intensive services like problem-solving courts, and clients that have many of these destabilizers that are listed here, those are clients that need more wraparound services and more assistance in making sure that they can meet their target goals. We know for a long time that the match between putting people into services and being able to actually deliver the needed service to the client is a difficult process, one that many problem-solving courts, prosecutors, judges, corrections, probation and parole officials all struggle with. And so my team has developed a decision support tool to help people in making these decisions. We also, as part of this toolkit, have a mechanism to be able to review the quality of the treatment programs and the court programs, as well as to do some gap analysis. And more information about this particular tool is available on our website. And it's something that SAMHSA has used with many of their offender reentry programs in the last several years. What's nice about this particular toolkit is that it helps us to basically take basic risk needs information and with some underlying algorithms that were constructed in order to see what types of clients do better in what types of programs. It makes recommendations on what type of person would be better suited. As I indicated, we have special formulas here for problem-solving courts. This is a quick process that is actually on top of your assessment process, so it takes about 5 minutes to complete because it complements your existing package of standardized assessments. One of the things that this particular program does is that it recommends different levels of care. Problem-solving courts are in level A, which are for people with high severity of substance use disorders. But we also recognize that sometimes you bring people into a problem-solving court that has criminal thinking with a secondary issue of slightly less severe substance use disorders. And that just means that the programming needs to change for that particular individual, and that's part of one of the things that we look at. Another part of the RNR simulation tool is the ability to actually look at what's going on within your interventions. As I said before, we're able to do this both for the therapeutic component, but also for the problem-solving component. And this is a approximately 1 hour online survey that your treatment administrators and or your court administrator would complete. Or sometimes both of them would need to complete it. It basically ranks the program in terms of the use of the RNR principles, and then it gives a cheat sheet on how to make improvements in your problem-solving court. So, for example, in this particular court, implementation is modest in this court, and it would actually help to define those components of implementation that would enhance outcomes. Another part of the program tool is it will rank your program compared to other programs on different dimensions that are very important in assessing the quality of services. So we know that we struggle in this country, with making sure that we can provide appropriate quality services for clients. And this is one way of programs being able to do a quick assessment, actually learn from them about their own program, and then gives you, like I said, this cheat sheet of ideas. We've recently just added some new implementation scales to look at how quality assurance, the use of rewards and sanctions, and the use of clinical standards in substance abuse treatment programs, including those that work with problem-solving courts. And finally, the toolkit does this gap analysis, sort of my favorite part here. It allows you to look at your population and to compare your population against the types of services that they would most benefit from. And all of this is available on our website, and if you have any questions, feel free to contact me or my team. So overall, what's important here in the problem-solving courts is that we deal with making sure that we're tailoring things to the individual, that we're providing for systems issues, and making sure that treatment and services are integrated within the court structure, not secondary to. And I know with medication-assisted treatments, this is a major challenge because oftentimes the providers are subcontractors, but we really need to begin to really think about some of these systems issues to make sure that the clients are getting the most integrated care. And then our biggest challenge is providing high-quality programs, both in terms of the nature of the treatment courts, but also in terms of the nature of the treatment services and any medications, so that all of these pieces together can be used to make sure that we have the strongest problem-solving courts possible. So the RNR simulation tool is just a toolkit to really help facilitate some of the decisions of problem-solving courts, but these decisions have to do with who's eligible, what types of services do you offer, and what is the quality of those services, and then are you providing the full range of services for the clients in your problem-solving court. So with that, I'm going to turn the presentation over to my colleague, Doug Marlowe, and Doug, it's all yours.
Thanks, Faye. That was an excellent presentation. I'm not going to repeat any of the basic concepts of risk-need responsivity that Faye mentioned in their application of public health, and she did an extraordinary job with that. Drug courts integrate the treatment and the criminal justice field, and so we tend to think about R&R in clinical terms. And I will often use medical analogies to talk about R&R because medicine is a very well-established, mature profession. They have standards, they have guidelines, they have ethical codes, they have procedures, and that's something that we really should be emulating. So imagine that you haven't been feeling well for some time. You've been sick, you've been very concerned, you go to your doctor. And you tell your doctor, I don't feel well, I haven't been feeling well for some time, I'm very concerned, please help me. And your physician says, no problem, take this medication, it will fix you right up. And you say, now wait a minute, doctor, I've been to enough trainings to know that it needs to be an evidence-based treatment. Is this an evidence-based medication? The physician says, absolutely, it's been proven in multiple trials to improve outcomes, approved by the FDA. It is a evidence-based treatment, take it, it will help you. That physician has just committed malpractice. And in fact, that physician has committed malpractice per se, which means on its face, because that physician didn't do two things that a physician is required to do before treating. Number one, diagnose the patient. You are not allowed to treat without a diagnosis. And number two, prognose the patient. Does this patient have complicating factors that makes it less likely they will respond to a low-dose frontline treatment, and therefore I need to treat them more aggressively with a more potent intervention? Now, you might wonder, well, why don't we just treat everybody with our most potent treatments? And the reason is because treatments all have side effects, and the more potent the treatment, the more serious the side effects. And so if somebody has a good prognosis for a frontline treatment, it would be malpractice to treat them with a very intensive treatment because you are risking greater side effects with no better therapeutic value. What the medical system refers to as diagnosis and prognosis, the criminal justice system, the treatment system refers to as risk and need. Risk is essentially prognosis, need is diagnosis, and so we know from the risk principles, Dr. Taxman said, if you provide too much intervention, too much supervision based on somebody's risk level, not only do you not make them better, you actually make them worse by getting the side effects of a potent intervention. On the other hand, if you treat somebody in a too weak level with insufficient supervision, with insufficient services, the chronic disease process just continues and gets worse and worse. And in fact, people they actually build resistance to treatment. If you give people low-dose treatment, if you give people half the dosage of medication they're supposed to take, not only do they not get better, but they build resistance to the medication. So if later on, if they take the appropriate dose, they actually get worse. And so the reason we don't over-supervise or under-supervise is because we are risking side effects or and undermining the intervention. Need, if risk is the prognosis, then need is the diagnosis or the functional impairment, the what to treat. And so if you give somebody too much treatment based on their clinical needs, not only do they not get better, they get worse. And if you give somebody too little treatment, not only do they not get better, they get worse. We have actually found through painful experience that if you give somebody treatments that they don't need or more treatment than they need, you actually make their disorder worse. And part of the reason for that is that risk, like need, I neglected to mention this, risk and need, to borrow from the medical analogy, are highly contagious. If you take a group of high-risk people, you put them together in a group of low-risk people, you will get a group of high-risk people. The high-risk people will raise the risk level of the low-risk people, and the low-risk people will have no impact whatsoever on the risk level of the high-risk people. It would be like taking somebody who has a broken leg and putting them on the tuberculosis ward of a hospital. Now they have a broken leg and tuberculosis, and that would be malpractice in the medical field. Now, responsivity, which is the how to treat, the analogy is to case planning. It's to creating a treatment plan, a diagnostic plan. And what we have found is that treating needs in the wrong order makes outcomes worse. So if you give someone treatment they don't need, they get worse. If you don't give somebody treatment they do need, they get worse. And if you treat their problems in an inefficient, ineffective order, it actually gets worse. So the point here, I think, from RNR is that there are more ways to do it wrong than there are to do it right. And that's the way physicians are trained. They're trained from day one. Diagnosis, prognosis tells you how aggressively to treat, how what interventions to use, and then you create a care plan that sets out what you're going to do first. First, we're going to do surgery, then we're going to do radiation, then we're going to do chemo, whatever. Has to be in the right order, because if it's not in the right order, the case will not get better and indeed might get worse. So most or many treatment courts in the country have adopted what is called the Quadrant model, and Judge Davis will be speaking about this shortly. The Quadrant model says that if the appropriate interventions for people are based on diagnosis and prognosis, then broadly speaking, you have four types of people, speaking very broadly. You have people who have a high risk for treatment failure or a poor prognosis, and they have a high need. So somebody with a severe addiction who also has a long history of treatment failures. Somebody who has a severe addiction but also has antisocial personality disorder, and their criminal associate, everyone they hang out with are themselves engaged in criminal activity, and they have an early onset of criminal conduct and multiple prior convictions. So they really need treatment, and they have a poorer prognosis to succeed in a standard intervention. For those people that we call high risk, high need, they need four legs to this stool. If any one of these legs is missing, the case must fail. The first leg is supervision. And among the different things that we include in supervision, there are many, would be what we call status reviews. So status review for a behavioral psychologist is when somebody meets with the participant, somebody who has the power and authority to do something meaningful to them. So if I have the power to give you a sanction you really don't want, or to give you a reward that you really do want, if I have that power, then it would count as a supervisory meeting, as a status review. And so people who are high risk, high need to have frequent status reviews. And what our research says is approximately, to start, at least every 2 weeks or more often, they need to come to court, appear before the judge for reviews. Now, we suspect that for people on probation, it would be equivalent if they were meeting with probation officers. Most of our work has been in the drug court context. Point here is that treatment does not count as supervision. You can't send people to a treatment program and say, okay, they're going to be supervised there, because treatment professionals do not have the authority, the training, the expertise, the inclination to impose substantial rewards and sanctions. It's not their job. In addition, and supervision would also include drug testing, it would include community surveillance, it might include GPS monitoring devices. It means knowing what the person is doing and responding if they are not showing up at treatment or committing other infractions. Treatment, critically important for this population. Dr. Taxman discussed some of the aspects of treatment. It must include medication-assisted treatment where indicated. It should be behavioral and cognitive behavioral in orientation. It should be manualized, structured. It needs to be evidence-based treatment. Then there's something we call pro-social habilitation. Many of you may be familiar with this using interventions like thinking for a change, or moral recognition therapy, MRT, or reasoning and rehabilitation. These are interventions that focus on the sometimes criminal thinking, what the 12-step community would call stinking thinking, tendency to see oneself as the victim rather than the perpetrator, not to think before one engages in impulsive behavior, not to consider the consequences of your behavior. So in addition to treating the clinical disorder, the addiction, mental illness, you need to address this dysfunctional thought patterns in this population. And then adaptive habilitation is the job training, the literacy courses, learning to open a bank account, parenting skills, those kinds of interventions that help people to function effectively in the community. And I'll get to this a little more in a bit, but the order of these interventions is critically important. That if you start, as many programs do, they start somebody's on probation and they are told, in the first weeks of probation, they need to get a job, or they need to re-enroll in classes, or they need to, get a driver's license or whatever. You're moving on to these adaptive habilitation components when you haven't dealt with all of the other issues in their lives that are more pressing. So that is the high-risk, high-need group. If any of those elements are missing, the case must fail, and that is your treatment court group. That is what drug courts were created for. People who are high risk for treatment failure, high need for substance abuse treatment, very often have very antisocial lifestyles and very poor job skills. They need the whole gamut of interventions. Upper right quadrant, people who are low risk but high need are individuals who may have severe addictions, but they don't have those risk factors, those poor prognostic indicators. We are actually seeing more and more of these low-risk, high-needs people in drug courts as a result of a few things. One is the opioid epidemic, where a lot of people are being introduced to and becoming addicted late in life. People who had an injury in their 20s, 30s, 40s, 50s become addicted to these opioid medications. They were high-functioning before that, so they don't have these risk factors for treatment failure, but they have very severe addictions. For these people, you don't need and should not engage in these very intensive supervisory interventions. They actually get worse if you make them come to probation or to court and spend lots of time with the other high-risk people. What they need is pro-social rehabilitation and adaptive rehabilitation. You're really returning them to a previous level of functioning that was lost in many cases. And these are the people that should be diverted out of the justice system into treatment, with the justice system making sure they go to treatment. So probation is saying to the treatment providers, make sure they're there. If he's not showing up at treatment, let me know and I'll intervene. But treatment is where the magic is, where it's the special sauce for this population. Lower left quadrant, individuals who are high risk but low need. They don't have these severe addictions, mental illness, and other things, but they have risk factors for failure in supervision and for recidivism. Very often they may have antisocial personality disorder, they may have gang affiliations, they may have multiple failures on probation before, long criminal records, but they do not need and should not have substance use treatment. If you're sending these high-risk, low-need people to programs like drug courts, and there are many of them in drug courts, when they don't need drug treatment and the whole basis of the intervention is drug treatment, you are mismatching. And when you give treatment to people who don't need it, you make them worse. So these people need the intensive supervision. They will need the criminal thinking, pro-social rehabilitation, job training interventions, and examples of programs that tend to be more effective for those are ISP programs when they include intensive supervised probation programs when they include the cognitive behavioral counseling interventions that Dr. Taxman mentioned, HOPE, Hawaii Opportunity Probation with Enforcement, which is a sort of a court-supervised, probation-implemented, close supervision, contingent consequences if people aren't doing well. They do not need and should not be in drug court. The lower right quadrant, people who have neither of these things, the high risk nor the high need, you've got in trouble, but they don't have a serious addiction. They have a good chance of learning their lesson and not moving forward. These are the people who should not be in the criminal justice system at all. These are the people who should be diverted, and even the new term now is deflected, so that they're not even arrested. They're deflected even at the police encounter. These are the people best suited for a full deflection. I'm not saying that you couldn't also do a law enforcement diversion for the other cases, but they would need services, whereas these are the individuals that we could put in a diversion program, what many probation departments will call banked probation, where they just have to let their probation officer know if if they change jobs or move, but other than that, they don't need to be very regularly involved in probation and the like. Specific responsivity, I'm going to move on right after this. We talked about the importance of the order and timing of intervention. Dr. Taxman used the term stability factors. We use the term responsivity needs. I think they're very similar. Responsivity needs are the needs that interfere with rehabilitation. They're the things that if you don't address them right away, you can't get to anything else. If someone's homeless, there's no point in talking about their criminal thinking. If someone's homeless, there's no value in talking about their substance use. If somebody is suffering from severe mental illness, so you have to stabilize the case so that they can then respond to the treatment focusing on their criminogenic needs. And the big criminogenic needs, as Dr. Taxman said, are criminal thinking, hanging out with a delinquent peer group, addiction, drug use. These are the family dysfunction. These are the major criminogenic drivers of crime. After those have been stabilized, then you move on to what we call maintenance needs. These are the needs that don't cause crime, but if you don't address them, the case falls apart as soon as they leave your program. So this is where employment comes in. We're getting your GED. We're opening bank accounts. Learning how to adapt. Those are your adaptive skills. Humanitarian needs are other needs that cause distress. That, of course, if they're life-threatening, we're going to deal with them right away. But if someone has dental problems or other things, we're certainly going to refer them for those services. But you can fix their dental problems. It's not going to have any effect on their criminal activity. It's just you should do it anyway. And then we get to what we call the restorative justice needs, which is the restitution to victims, community service, giving back, and assuming a law-abiding stance in society. Many programs require participants to get a job and start paying restitution right from the beginning, when those should be at the end of the intervention after you have addressed their mental health issues, their homelessness, their addiction, and the like. Since we don't often have people long enough to address all their needs, that's where your continuing care plan comes in. If person only gets through maybe the third level and they're dealing with employment skills, that's what you need to set up to make sure they continue in this correct order of intervention after they leave your treatment court or probation or the like. The important thing here is that each phase advancement, each time you move through those numbers, increases the odds they'll pass the next one. So if you get someone stabilize their responsivity needs, you increase the chances you will be able to stabilize their criminogenic needs. Stabilize their criminogenic needs, you increase the odds that you will be able to address effectively their maintenance needs. The opposite is also true. If you skip a need or you fail to address it adequately and you try to move on, the odds of them succeeding at the next step go down. And that is why the order of intervention requires considerably more thought than just throwing the whole kitchen sink of interventions or whatever interventions happen to be available to a program, just making them do what you say, this is our menu of services. That is not the correct way to manage these cases. In conclusion, it is impossible to do evidence-based practices unless you have assessed risk and need prior to disposition, for example, as part of a PSI. Just as it would be malpractice for a physician to treat without a diagnosis or prognosis, I would argue that it is malpractice for any of us to do anything to people who are under our control, supervision, authority, when we don't even know what we should be intervening on. That acting without a risk need assessment is essentially malpractice. Of course, you have to give people what's called use immunity, which means any information they give you in the course of the evaluation can't be used to substantiate criminal charges or augment their sentences exclusively for setting their treatment plan. Using valid, reliable, and culturally unbiased instruments, of course, is critical. I would make the argument, though I know there's a big backlash out there right now about risk needs assessments may exacerbate racial and ethnic disparities. Everything that we know, we don't know a tremendous amount, but every study that's looked at it has found that that when you use risk and need assessments, racial and ethnic disparities go down, they don't go up, because you're following evidence-based practices instead of personal biases and beliefs, which tend to lead us in very discriminatory ways. This is a segue to Judge Davis, that therefore it is important in treatment courts, if you are going to treat people who are not all high risk, high need, you must have separate tracks to avoid mixing up your populations. And ideally, you should automate the if-then decisions. You know, if the person's high risk, high need, then they go in this track. And if they have these responsivity needs, they're dealt with first. That kind of information can be and should be kind of systematized in your policies and procedures manual so that your program gets used to setting up care plans that way. And with that, I'm going to pass it on to my distinguished colleague, Judge Davis. Thank you.
Well, thank you, and hello, everyone. Thank you, Dr. Taxman, and thank you, Dr. Marlowe. You know, for those of us who have our boots on the ground, these concepts were wrapped up beautifully. And so we have this great package in front of us regarding risk needs and making sure that the people that we deal with actually become productive citizens. And then we turn and go to court, and it's a lot more difficult to implement than it appeared in this 40-minute discussion, as our hosts know. So what we did in Greene County was we looked at this concept, and we looked at the risk need assessment, and we were required to do that by the Supreme Court. And then most of us thought, well, if we do that, what do we do next? And so I'd like to explain to you kind of what our treatment court model looked like when we began to actually use the risk need assessment and divide out our participants according to their need. And so I'm excited to share with you what we have. So let's see if we can go there. In 2013, we implemented the 4-track model, or the 4-quadrant model, in our treatment court. We were not able to actually put people out of the system because we're post-plea for large part. And so we just kept a lot of our folks, but we thought this would be a way, quite frankly, to reduce our cost. But what we found was it also increased our outcomes dramatically. And the tool we used was the risk needs triage, which is the RANT. And we would administer the rent prior to people coming into the treatment court program. And then we would look at what we had once we did that. And so our objective was to match our risk need through screening and assessment, match our supervision level to the risk, and then conduct a clinical assessment and match the treatment services or clinical services according to the need that we saw in front of us. A lot of us who've done criminal justice for a long time on the ground have this tendency to think that if a little bit is good, more is better. I remember judges would say to me, well, I know if an individual was caught with drugs in their purse, that they had a substance use disorder. And we were all guilty thinking that. So we would throw a ton of services at people thinking we were doing everybody a favor. And as you'll see on some of the data that we have, I think we actually made people worse. So we learned that the things that Dr. Taxman and Dr. Marlowe are talking about are exactly the things that happen when we employ these practices either correctly or incorrectly. So the first thing we do, I'm not going to spend a lot of time on this because we've already talked about it, but remember, if the risk is high, we match our services to the risk, our supervision services. If the need is high, we match our treatment or clinical support to the need level. So track 1. Or quadrant 1 was the high risk, high need individual. This is your traditional drug court. I'm not going to spend a lot of time on this. This was what our drug court looked like. But what you will note and you will see is that it is everything that most of us do who try to follow best practices with drug court. Particularly, there's substance use treatment included in this track. There's non-compliance calendars. There's status hearings with court. There's that ability to respond to their behaviors immediately. And we also included cognitive behavior therapy in order to address those thinking errors. So this is the whole ball of wax. This is everything that we want to see, and this is where we put everybody for a long time in our program, regardless of risk needs. So we divided it out, and those who screened high risk, high need, and screened with the clinical assessment to have the need for treatment got the traditional drug court, which is track 1. And then track 2 was the low risk, high need. And so track 2 was that population, as Dr. Marlowe talked about, that, maybe an older population, and that's indeed what we saw, who may have gotten involved in the opioid issue with the injury and then found themselves dealing with a substance use disorder. We realized we don't need to supervise them at a high level. But we did need to give them clinical support and substance use treatment. And so here's what the actual program looked like. If you'll notice on the first bullet point, the court status hearings were only once every 3 months or as needed. So if somebody came into that program and had a need to see the judge earlier, we would certainly see them. I did touch base with them occasionally and found that to be effective in reinforcing that we were there. We had a program that they could actually complete and know that they finished. Had a lot of positive reinforcements and treatment, medication, the things that the individual needed, but it was not focused on supervision. Because if they're truly track 2, we found they didn't need that supervision piece. They didn't need to come to court, but they certainly needed treatment. Then track 3. This track surprised me a little bit. This is the one that is high risk, low need. And so these individuals have the high criminal history. They have a criminal behavior and a lot of criminogenic needs. However, they did not assess as having a substance use disorder. And so the essence of this program, if you'll note on the next slide, looks very, very much like our traditional drug court. However, one thing is missing, and that is substance use treatment. We did look at where needs were for folks. Sometimes there were PTSD issues or trauma kind of based services that these individuals need, but they certainly didn't need substance use treatment. And so it was very similar to what you see in the treatment court, but we did not send them to our treatment providers in order to mix them with the population that we've seen prior to this discussion. Track 4, that low risk, low need individual. I always think of these as the college student that grandma gave a Xanax at test time and said, take it, it's good for you. And of course they get caught and they pick up a felony. But these young people generally are not going to come back. And so we did a very minimal supervision piece, and we actually looked at prevention or education. So you'll see our track 4 did not see these individuals very often. And again, saw them as needed. If there were some issues that we needed to address, you will look at the pieces in regard to responses. We had some education classes. And then one of the things that we did include in addition to the education classes is we did do an individual session or more based on need, looking at what kinds of things drove this behavior. May not need to be a big individual or long-term individual counseling session, but it helped identify those particular issues that were driving behavior and oftentimes intervened with a slide downhill. We did do some drug testing. As you know, we wanted to make sure that our assessments and our screenings were accurate and that we were able to identify. And so we would test periodically for a while to see really what we were looking at. Not as much supervision again, and so we had that track. What we learned was that these adjustments or these screening tools are a snapshot of the individual's needs. The reason that we continued to keep our fingers on folks for a bit was occasionally we found that through people who are treatment savvy or people who are savvy with the risk needs assessment, we really didn't get an accurate picture. It did not happen very often. It was a unique experience, and it rarely happened, but we did have the ability to, if we saw behaviors or we saw needs that we thought were more, we would again assess, look at what we had, and had a system whereby we could transfer people from one track to the other based on what our assessments told us after we got to know our individuals. So here's the lessons that we learned. We learned that you shouldn't miss risk need populations, and we learned it through our data, but we also learned it through focus groups that we're going to talk about. And a couple of things also that we learned, and it's a little difficult sometimes for judges who have their feet on the ground and so many other responsibilities, but the court docket shouldn't be mixed. When we talk about changing behaviors, it's important that people understand why we're responding the way we respond. And the danger in mixing those court dockets is people don't understand always why you've got a different response to somebody who does not have a substance use disorder and decides to use opiates over the weekend. That's going to be a different response than somebody who's in the high risk, high need population and early on test positive for opiates. That would be, in the last example, that would be a treatment response, and in the first example, it would be a more behavioral response and a stricter sanction. If the dockets are combined, my suggestion is that you bring them in, even 15 or 30 minutes apart, and be very, very clear in court why we are doing different things for different folks, so that explanation is there, remembering that courtroom is theater. This was one that is a challenge because we have these great ideas, and then we go back and we try to implement it, but our treatment providers don't work for us. So this process that looks fairly simple took about a year to implement because we had to go back and educate treatment on our expectations. And treatment, a lot of times we would find, would mix people in groups on risk need level, not understanding exactly what we were trying to accomplish. So one of the things we need to be real clear with when we're talking about how to do this is we didn't want groups mixed. We didn't want to have the same different people in different groups, even if the topic at group was the same. And so in small programs, it may be that you want to consider just using individualized treatment for your different populations. Supervision. It was really preferable to have POs or supervising officers have a caseload specific to the risk need level. It kept the POs focused. people talk, as you well know, who are in this criminal justice community, and it kept them focused on the PO that they had, and they didn't say, well, this PO was nicer to Joe than he was to Sue, not understanding that there were different risk needs level. And then our officers need to be educated about the difference in responding to people based on their risk need levels and proximal and distal behaviors. So we are consistent in our court responses and our responses in regard to treatment services. So we need to take time to plan. We have to educate our team members. We have to educate treatment. We have to get everybody on board on this concept, and then sit down and actually look what the program looks like, look how it works from day to day in the operation, talking again, referring back to the group sessions. You know, if you don't have enough people in a particular risk need level to hold a group, then it's better it's probably better to hold individual sessions. We look at supervision expectations. Again, the officers look at what they can expect, what behaviors they're going to respond to, have realistic expectations about what success looks like at each phase, and then identify our treatment. Substance use treatment for the track 1, not substance use treatment for the track 3, and then no treatment for the track 4, and then track 2 again. We need some pretty intense treatment, but not a lot of supervision. We need to revisit these expectations. Again, once you're used to doing business one way, when you start changing things and you have people really changing their approach to things, it's important to revisit with your team members and say, how's it going? What are we doing? And keep that expectation tight as we adjust to this change in the way we do business. And so we were really fortunate in the state of Missouri in that we wrote for a grant with SAMHSA, and this grant study began in 2014. We were in Missouri accorded this grant to do an evaluation on the 4-track model, and the 2 jurisdictions in Missouri who were the research sites was Jackson County, Kansas City, Missouri, and then Greene County, Springfield, Missouri. And so we have this evaluation back. It was completed in September 2018, and the evaluation was conducted by NPC Research. Dr. Shannon Carey worked closely with our court, and I'd like to share some of the results with you on what we learned through this process. Let's go back. All right, the first thing we learned that I thought was significant was we had higher graduation rates. And if you look at this, it's interesting. Pre-4-track models, all of our drug court folks who went through drug court prior to implementing the 4-track model, we had a 45% graduation rate. And we had always taken a good dose of high-risk, high-need participants. After the 4-track model and tracking out 3 years on this, our graduation rates went up to 68%. If you look at Dr. Carey's work on this evaluation, what she noted at the time was that the national average was 57%. And so we not only were able to exceed our graduation rates or improve them by over 20 points, but we were able to improve them over the national average by 11 points. And as we know, graduation rates are a good indicator of how individuals are going to perform after the drug court program. This is a slide that shows you what it looked like after people graduated from the program or the other comparison groups. And what we note is that we had less reincarceration. So if I can kind of explain this to you, the red or kind of dark brown bar is a comparison group of individuals who cases would have been accepted into drug court but did not come into drug court for one reason or another. And then the light tan bar are individuals who were in drug court and completed the program prior to implementing this program. The blue are our post 4-track comparisons. So these are the individuals who were placed in the program according to their risk need. And then that's the comparison group. So they were, again, those individuals post 4-track, who would have come into drug court but did not for one reason or another. And then the light blue track are those people who completed drug court successfully after and went through drug court on that 4-track model. So if you look at this, the first year out, the pre-4-track comparison group had a 28% reincarceration rate. And what I think is interesting, sometimes evaluations are painful to look at, our pre-4-track drug court actually performed worse. And, I think the takeaway from this, and it'll be interesting to see what Dr. Marlowe has to say in a minute, but the takeaway from this is this really shows me if you're not treating people according to their risk need and you're not giving them what they need, you make them worse. And this tells us that. But if you look at the light blue, we really improved outcomes, significant drop, 30% compared to 39% on our comparison models. And then look 2 years out, again, 36% less than the other comparison groups, and 3 years out, 36%, significantly less than the comparison groups. And our data got better. Our people did better. The further out we went, they consistently stayed where we wanted to be, which is in the community and performing as law-abiding citizens. This is reductions in recidivism, those cases that came back into the system, either arrest for felonies or picked up a new charge. And what, again, we see is very, very interesting. Same bars, same designations. But if you will look, again, that light tan bar, which are our pre-drug court people, first year out, we really didn't have a lot of bragging rights. Again, I think this tells us that when we're mixing folks, we're not helping them. But if you'll look at the light blue bar and our comparison, you'll see that we had significant reductions in recidivism. We had less property and persons crimes because we take a host of individuals in our court. We had 50% approximately less drug-related rearrest, drug crimes, and 3 years out, you can see that we continued to maintain those outcomes. I'm going to do this real quickly, but for those of us who are not evaluators, these focus groups, I thought, said beautifully what we're seeing, and that is the Quadrant 1 people, when we did focus groups, complained a lot, but they also recognized that the program saved their lives, and they were willing to call each other out. They also talked about probation burnout. Whenever they were in programs that continued forever, they give up because we keep after them for so long that that ceiling effect where we lose our ability to make a significant change with people. On the track 2 people, and that's the people without a lot of criminogenic need and the substance use disorder, they were appreciative of the services they had and they were more supportive of each other. Track 3 worked on criminal thinking and said they never really fit in with treatment court and treatment groups. And they told me that in court too. They had a lot of high collateral needs, but they did very well. This was one of our best performing groups when we look at the data. And they did well, I think, because they didn't have some of those responsivity factors running against them, such as mental health disorders and substance use disorder. And then the folks that kind of drop into our system for a host of reasons, but really don't have those high criminogenic risk factors or needs. I thought it was interesting. They said they were scared of people in the court. This wasn't where they felt like they belonged, and they performed better. And so you can see some of the comments that people had. People said, I like the different tracks. This person had a little experiences early on in our system and understood that it was different beforehand, and so said that they didn't have to spend all the time going to treatment and could work and be productive. This person, these people talked about that, again, we focused and they were able to focus on the issues that drove them into the system. And then this is a quote from Shannon Carey at the end of her evaluation where she said, it seems clear that using risk, need, and responsibility responsivity in a drug court setting increases public safety, lowers criminal recidivism, and has a substantial cost savings to the taxpayer. And it was during that evaluation that Dr. Carey was able to identify that we were saving about $4,733 per participant per year. And if you look at the average, which we normally ran of 300 individuals for a year, that was $473,000 in tax savings per year. Running out, it increased to over $7 million over 5 years. And so we make a big difference in our community. I want to commend all of these researchers who said, trust us, do this. And then I'm here as a boots on the ground person to tell you I'm excited. This apparently works and makes a tremendous difference in the effectiveness of our programs. And with that, I'll turn it back to our lead person.
All right, thank you so much, Judge Davis. And thank you to all of our presenters. We were just presented a lot of really great information. And so now we are going to take some time to go through your questions. And some of you may have seen something just pop up on your screen. The box is entitled File Transfer. So we do have a couple of handouts that we are sharing that will hopefully help you as you proceed and try to implement some of this information. The first document is an RNR, kind of a matrix of tools that are commonly used in applying RNR at the practice at the drug court setting. And then we also have a fact sheet on RNR. So both of those are available. You can click on them and download them directly to your computer for more information. And so at this time, I'm just going to go through the questions that are being submitted in the Q&A portal. Once again, this is to the right side of the screen, and we welcome you to submit any other questions you may have. So starting off, and this question, I would say I think any of our presenters can answer this. So the person asked, would you say a reentry court would target people with a higher criminal thinking need over substance use disorder if for no other reason because that person may be more suitable for drug court? So any response to that question in terms of what a person with a substance use disorder may be more appropriate for versus considerations of higher criminal thinking needs?
So this is Doug Marlowe. Can you hear me?
Yes.
Am I okay? So yeah, I'm not entirely sure I understand the question, but let me take a stab at it. So I think that when we look at reentry court populations using tools like the RANT and other tools, we do find that a higher proportion of them tend to fall in the two left quadrants, either the high or the high risk, low needs. We do get a higher proportion of those individuals. In terms of whether they would be more suited for a traditional treatment court as opposed to a reentry court that doesn't include an emphasis on substance abuse treatment, that would really depend clinically on the case. Some people make a mistake of thinking that because somebody's been in custody for a substantial period of time and they're no longer, at least not currently, suffering cravings or compulsion or withdrawal, that they are therefore no longer addicted, and that's not the case. As soon as they're released, if they had a pre-existing addictive disorder, it's usually awakened quite rapidly. And so, if they went in with an addictive disorder, then they would be high risk, high need, and a reentry drug court would certainly be appropriate.
This is Judge Davis. I agree with Dr. Marlowe. I would like to say that if you have the opportunity, that population that does not have the substance use disorder and you can treat them in treatment court, they can do very well, but don't mix them. So I think there's an opportunity there for both, but it's really a situation where you need two different kinds of programs for those populations. So you need to decide which one, if you have limited resources, you want to focus on.
Any other comments?
No.
Okay. All right. So the next question is also kind of on the substance use issue, more specifically about DWI, OWI charges. I'm going to try to read it to you exactly how it's written. Many OWI thirds, which is apparently one of the higher levels of operating while intoxicated charges. So many of OWI thirds and higher come with a lower risk and moderate to high needs. She said, we use Compass. Problem is this is not appreciated, thus encouraging the lookout for a tool that will make the risk higher. I'm not sure I understand the complete question, but it seems that they're struggling with understanding how to address the needs of people charged with OWIs falling at lower risk but moderate to high needs. So any comments on that?
Go ahead.
I'm sorry, Doug, I was just going to tell her that she's exactly right on what we saw with DWI court, and I want Dr. Marlowe to respond to this. And that is that traditional risk needs assessments, I think, underestimate or underscore those folks considering the risk of dangerousness, but they don't pick up as high risk, high need on traditional assessments. I think Dr. Marlowe is more adequately equipped to address this.
Well, I would just underscore what you just said. What a lot of studies have really shown is that risk tools sort of, in many respects, systematically under-assess risk. And what I mean by that is that you get a very high false negative rate, or a much higher false negative rate. So somebody comes out as low risk on a DUI individual comes out low risk on a tool, but in fact has a high recidivism rate. And so the tool is missing the propensity for recidivism, the propensity for treatment failure. And the reason for that is because these tools were really originally developed for we developed tools based on risk factors that, number one, are highly predictive and also need to occur with enough frequency that they can actually differentiate populations. And the risk factors for treatment failure in a DUI population or OWI population tend to be, and they overlap with those of a more traditional drug court or offender type population, but they're different enough that you're missing it because you're not asking the right questions. And so I know that the American Probation and Parole Association recently developed an instrument, and I'm blanking on the name, it's like the drunk driving assessment or something like that, where they actually, they specifically validated a tool using the kinds of items that predict DUI recidivism specifically. So for example, most risk tools, the LSIR and the Compass and others, generally don't ask what was your BAC, your blood alcohol level at the time you were arrested. But that is highly predictive of recidivism in a DUI population, so you want a tool that asks that question. How many traffic violations, speeding tickets, parking ticket violations, these are things that are not particularly predictive and not, they're not necessary in a more traditional criminal justice population where most of them don't even have cars. But for a DUI or OWI population, those things are very predictive, and so you need different tools. And so there are a few out there now that are specific to that population, and so that I think you really need to select a tool and try it out in your population.
Thank you, Dr. Marlowe. Any other comments in response to that question? All right, so the next question kind of transitions a little bit more towards the practical challenges that some of the drug courts face. So this person asked, we are struggling with limitations on Medicaid coverage for lengthy treatment. In fact, even being able to justify a full 12 months of substance use disorder treatment is very difficult, let alone lengthier times. Any recommendations for working with Medicaid on this problem?
Okay, this is Doug again. I might I make a few recommendations. There are a number of resources out there now. There are ones developed by the Legal Action Center, the LAC, which you can download. There's a SAMHSA resource guide that I've been writing that will be out very shortly. There's the National Academy of Sciences just came out with a report literally in the last month, all of which review how long medication-assisted treatment should last. And the short answer, the simple answer is that even to attempt or to talk about or even begin a tapering regimen in less than 18 to 24 months is almost always associated with treatment failure. So if you are, so there is no scientific basis anywhere for reducing any of these medications in less than roughly a 2-year period. And that doesn't mean you should do it in 2 years. It just means that you don't even start thinking about it and introducing it into your care plan until at least 18 months out. And so the way to lobby for this, if that's that's the wrong word, but you can actually you can actually download materials from the LAC website where they're just literally sample letters that you can send to funding agencies and to jails and to judges and other people who are engaged in what is clearly ineffective substandard practice, and say, the following organizations say don't do this. But that's the way to advocate for it. And I would definitely point you to it's the National Academy of Sciences, Engineering, and Mathematics, NASEM, just came out in 2019. The national report by the leading researchers in the the country. But the WHO, the World Health Organization, has one. The Surgeon General, our Surgeon General, I think, published one last year. All of which says that that these regimens must be measured in years, and that anything less than that is incompetent care.
Do either of our other presenters want to comment to this question?
I don't think I could improve on what Dr. Marlowe said.
Okay. All right. So now transitioning to a question more about the tools. This person said our district courts struggle with the cost of these tools, and most are currently using the needs, which doesn't really meet this type of assessment. So apparently they're struggling with having the right tools due to the challenge of cost. So any comments as to how barriers due to cost of assessment tools and how those could be overcome?
At the risk of always being the one to open his mouth first, I'm sort of known for that. This is Doug again. So there are highly effective, validated tools out there that don't cost anything. Certainly the ones that are most studied out there do have costs associated with the level of service inventory, for example, and the Compass and some others, have costs associated with them. But I think the question was more around the clinical side of it. So there are instruments like the Addiction Severity Index, the Global Appraisal of Individual Needs, Texas Christian University, drug dependence. There's a series of tools that give you assessments of addiction, dependence, and comorbid mental health and social service needs that the instruments themselves have no cost. They're not copyrighted. They're used all over the country. The issue, though, is garbage in, garbage out. And so if your evaluators are not trained and competent, then it's not worth doing. And so somebody in your team needs to be trained on risk need assessment. We sometimes use the word clinical case managers for these people, and we don't just say case manager because that's a very generic term and applies to anything. But so a clinical case manager is going to be somebody with some kind of clinical background, usually social work or psychology or counseling, who knows how to ask the questions in a way that gets good quality answers about, Dr. Taxman gave you that taxonomy of when use is compulsive as opposed to when it's risky, and being able to get a quality of that, of the compulsiveness, the level of pathology, and that requires clinical training. So somebody in the team needs to be trained, preferably more than one person, but at least one. We have found in drug courts that ideally there would be 2 people on the drug court team, assuming you were treating a large number of people. If you have a drug court with 20 people, that's one thing. But if you have 300 people, then you're going to need at least 2 highly trained, clinically trained case management types who know how to do these assessments. And they can get their training through something called TASC, T-A-S-C, Treatment Accountability for Safer Communities, I think it stands for, where they're trained how to do that. But the instruments themselves, I mean, some of them cost money. I'm not saying anything negative about whether they cost money, but there are ones that are free.
All right, thank you. And I think this question might be more for Judge Davis, but the other panelists, please feel free to also contribute. This person asked, are there due process issues when you place a participant to a high-risk, high-need track when that track is longer versus a shorter track? Who makes that final decision? Is there an appeal process?
That's a really good question, especially considering all the law we're getting in treatment courts in regard to constitutional issues. And I'll have to tell you that we've not experienced that. One of the ways to avoid that is to conduct that risk-need assessment prior to the individual actually making a decision to enter the court. And that's the process we followed. So if somebody, for example, is referred to the court, then the risk-need assessment would have been completed, and the score, and it just gives you a score, would be relayed to the defense attorney and the prosecutor's office, and then they would decide, knowing what the program was going to look like for that individual, they would decide whether or not to accept that offer and come into the treatment court. So they knew before, the individual knew before they ever signed the contracts for treatment court what their program was going to look like, with the caveat that if the risk-need assessment was inaccurate, we had the authority through probation revocation hearings or those kinds of things to make adjustments. I did not have anybody ever over the almost 8 years now, I didn't have anybody ever raise that issue. We make conditions of probation all the time for folks based on the cases and the information that we have in front of us. And that's what this does, is tell us, what is effective in regard to our conditions of probation.
Yeah, I would just add to, I'm sorry, go ahead.
No, I was just asking if anyone else wanted to comment.
This is Doug. I would just add that the governing constitutional test is a rational basis test, right. As everybody knows. There has to be so that the conditions of supervision must be reasonably rationally related to the person's crime, likelihood of recidivism, and rehabilitation needs. And so you're more likely to have your conditions struck when you don't do a risk-need assessment and you don't match the conditions to that, when everybody in my drug court must get the same treatment, when I just have a one-size-fits-all, that's more likely to be unconstitutional than having a tracking approach like Judge Davis does, where you are, by definition, matching the supervision and treatment conditions to the person's rehabilitation needs and risk for recidivism. So I actually think that most drug courts that are violating the Constitution are doing so because they're not doing what Judge Davis is doing.
All right. And this may be our last question, depending on how long the response is. But this person asked, any lessons learned on communication and coordination between the treatment court providers and probation? For example, should providers or probation officers meet regularly to coordinate care? How often? And what kind of things should providers communicate to probation officers and vice versa? I know that's a pretty in-depth question, but maybe just a high-level response would suffice from Judge Davis or anyone else who wants to speak to this question.
Well, I'll speak just from the boots on the ground position, and then Dr. Marlowe can jump in since he's got the science behind us. But the individuals, the probation officer in treatment, should be speaking all the time or any time there's a change or an issue that arises that may have some implications with the change in what the treatment protocol looks like or the supervision needs. So they need to be speaking with each other. And that's why when I talked about lessons learned, I went back and said that you really need to educate treatment and your probation officers before you institute this model, so that they understand between them exactly what expectations should be as to this individual, where that individual should be at any given point in time. If somebody's in an early phase in treatment court and they have a significant or severe to moderate substance use disorder, their performance is going to be different than somebody who has the high-risk needs but not a substance use disorder. And the best example I can think of is if we get a positive drug screen or we get a use, and then treatment and probation needs to be talking, but the response with the substance use disorder early on is going to be something we probably expect, so they need to be talking about how the treatment is going to respond to that and probation, whereas in the model where they're high risk and do not have a substance use disorder, then that's a behavior the individual has control over. And it's really important to understand those individuals will use, but just because you catch them on a drug screen doesn't mean that they have a substance use disorder. It's a behavior. And so that response would be different. And that's why it's so important to keep these populations separate, but they need to be talking, and then the court needs to be involved. And one of the things that I see increasingly, and we did, were non-compliance dockets, so that we were able to respond within a day or so of these kinds of behaviors, so the individual knew we were talking all the time. And so those kinds of issues the court and the probation officer needs to know. As to the details about some sexual assault that's created trauma, none of us on the legal side, I think, need to know the details, but we need to know that that's there because it affects the individual's ability to progress through the program and informs our opinions as to what success in each phase looks like. And I'll turn it over to Dr. Marlowe. He probably can run with the science on that.
No, I think in the interest of time, what I would do is recommend that the person asking the question, if you download from our website the Adult Drug Court Best Practice Standards, Volume 2 of the standards has an entire standard dedicated to the multidisciplinary team, so the communication frequency, what data elements should be shared. It includes probation and treatment. If it's in a treatment court context, this is directly on point. If the question is coming from somebody working in a probation or other type context, I think that the principles would be the same, and all the research behind why it is important to meet, how frequently, and that kind of thing is there.
All right. Any other comments in response to that question? All right, and just one last very quick question. Judge Davis, I believe someone was asking for clarification that the different phases used in the program that you shared about were of different lengths. Is that correct?
Yes. Well, yes.
Okay.
The individuals, we did a much shorter treatment court phase for individuals who were low risk, low need, and so it was based on their need. So yes, they were shorter.
All right. Okay. So there are a few other questions that we've not had time to get to, and where we are able, we may follow up with the presenters to get further questions. But I also want to highlight everyone to watch out for our third RNR webinar announcement that will be coming later this summer. So we will have a third presentation on RNR, and that will focus more on the reentry and community corrections settings. So please be on the look for that. The best way to keep up to date about our work and the information and webinars coming out of the Gaines Center is to sign up for our listserv. And we have a link, a URL for you to enter into your computer, and you can sign up through this link. It is case sensitive, so please do enter it in exactly as you see it. And once you sign up for our listserv, you'll get the slides for this webinar once they are ready. You'll also get a notification when this recording is available, and you'll receive our monthly newsletters and other notifications regarding our upcoming webinars. And if you have any other information or requests for information or questions, please do not hesitate to reach out either to SAMHSA, the information is on the screen, as well as the Gaines Center. So we have our website and direct telephone number listed. If there are any further questions that you would like to ask or any issues you'd like to troubleshoot with the Gaines staff, please don't hesitate to reach out to us, and we are here available to answer questions. And with that, just want to thank our presenters. Thank you so much for presenting this helpful information. I think from the questions you are seeing how much interest there is in the use of RNR and how much desire there is for this kind of information. So we really appreciate your time today and sharing with our audience further information about RNR. So with that, we will sign off. Thank you so much for joining us.